All right. So Megan and I have a special treat tonight. We are here with Dr. Jerenda Bond, who is a physical therapist extraordinaire in acute care, and she is also a PhD candidate at Rush University, and she is doing such important work. And so we just had to speak with her tonight and get her story. So Jerenda, that's my brief little intro of you, but I want you to share a little bit about yourself. Yeah.
Thank you for that wonderful introduction. I will tell you that over the years, I've practiced in every area of physical therapy except for home health. And acute care is definitely my thing. I feel like I'm stronger for my patients in the acute care setting, just from an empathetic perspective when they're just at that most vulnerable stage, being able to kind of meet them where they are. So I've been doing acute care for a long time. I've gone away from it and I always come back to it. And I think I'm here to stay in terms of clinical practice. And yes, I am working in southern suburbs of Chicago in a community hospital, small community hospital. And I am pursuing research at Rush University. I am out on dissertation, so I am actually recruiting for my study currently.
That is so exciting.
It
That's
is
exciting.
very exciting. You know, when I first started on the research journey, they told me select a research area that you are in love with, because if you're not in love with it, you won't be able to pursue it. And I get it. When the going gets tough, you have to be able to just fall in love with it all over again and just have that burning sensation for your research and then for the people who are going to benefit, and for the consumers of the research who are going to help other people who are going to benefit from the research. So I love research more than I love acute care.
That's amazing.
That is pretty amazing.
For those of us that don't really know what all goes into getting a PhD as a physical therapist, would you mind just giving us a brief overview of what that involves?
Yes, a PhD program is broken down into 3 sections: leadership, research, and then education. So by the time you're done, you are efficient in all 3 areas. So the classroom work is a combination of all of it. You have leadership courses that prepare you to not just run an academic center, but also to run a healthcare organization. You have education courses that will prepare you to teach learners at all levels and to develop curricular and activities and scholarship as well. And then you have research, which is not just actively pursuing the research, but learning how to critique it, learning how to build a research study from the ground up, and then all the nuances of being a part of a research team. When you're done with your classroom work, you have a qualifying exam, and different programs have different qualifying exams. Some examinations are a combination of artifacts where you would publish several papers. Some of them are written tests, some of them are oral. My particular qualifying exam at Rush was a presentation and an oral examination where I have 4 of my faculty members, including my research mentor, and they ask all sorts of questions about the 3 domains of the PhD course, being education, leadership, and research. Everything is fair game. And then you present your research to them. You present your research proposal, and they fill you with lots of questions, lots of fair questions. And once you get signed off from everyone and you pass, that's when you go into the dissertation phase. And at that point, it's all research.
I think that sounds so exciting. I think that sounds scary maybe to some, but for me, I'm like, oh my gosh, that sounds like such a challenge. I want to do it.
Before I embarked on it, I felt the same way. It just felt like a really big elephant. And it's interesting that you say that, because just today, being at the intersection that I am at with it, I was just saying to myself, wow, all these little bites, one bite at a time, and the elephant is almost eaten up. And it's amazing that, you know, you get through a class, you get through a class, you get through a class, you get through projects, and you just kind of keep moving. And so it's doable. You just have to want to do it, and surround yourself with people who are going to motivate you and support you. And I don't know that there is any PhD program that won't have people around you to kind of pull you into their bosom and help carry you along the way. So it's a whole support system in and of itself.
I think it's so fascinating to hear you speak about this because it's a lot of what we talk about from the patient education perspective. So one of our things that we always kind of share with people is break things down into smaller chunks. So now I'm going to tell my patients to not worry about eating the whole elephant.
Well, break things down into smaller chunks so that they are manageable and understandable for our patients. And just like each session, you know, we see someone and then we maybe not see them for another week or another couple of days or something, but we want them to be successful in those couple of days. We're not thinking about like the whole entire plan of care at that point or the whole entire curriculum, you know, being successful in those chunks, those projects that you were talking about first before moving on to those other larger chunks like a dissertation.
Absolutely. And I think you bring up a good point, the analogy between pursuing the PhD and patient education, because even though you're breaking it down into small chunks, as a therapist, you're thinking about the big picture and you're not throwing it at your patient because you want it to be digestible for them. And the PhD program is, like you said, just like that. It builds one class, one project, one area study. It builds and it builds and it builds. And before you know it, you have this whole composite of information and experience, just like with the patients. Before they know it, they are not just learners, but they become experts in their own story and experts in their own adventure. And they say, wow, look at all these things I've learned over all these weeks and these months in physical therapy. When I first started, I was so overwhelmed. I was in pain. I was uncertain about what was going to happen and what my outcomes were going to be. And you all have taught me so much, and I've learned it along the way. Thank you for doing that. And I think that's how our patients usually tend to respond back to us. I did it. You helped me do it. Yes. Yeah. The elephant one bite at a time.
I love that analogy. I think it's great. Before we get to your like specific research work and what your dissertation is going to be on, I want to ask you a little bit about patient education in acute care. So can you talk about like some of the opportunities for patient education in acute care, but then also maybe what are some of the unique barriers in acute care?
That's a great question. And I think one of the reasons that I love acute care so much is because it's not as time sensitive as some of the other areas of physical therapy. And so I find that I have a lot more real estate to explore patient education with the patients, and sometimes to just pull up a chair and sit down and to talk with them face to face about what's going on with them. It is when patients are usually at their most vulnerable state, because maybe they've just gotten some bad news that they're trying to process. Maybe their life has just changed in a way that they just could not predict, and so they're looking for help from any perspective possible. And so I find that approaching the patient as if they are their own expert and as if we are naive interviewers, if you will. We're naive investigators to say, hey, tell me your story. Tell me what's going on with you. And to meet them where they are in that vulnerable place. And then figure out together how to take steps forward in helping them move beyond where they are. I think that the barrier in the acute care setting is the same thing that's the strength, which is that sometimes patients can't hear everything that's going on because they have so much information coming at them at one time. They have a revolving door. The door to their room is a revolving door. They have one practitioner after another coming in, laying them with lots of questions and lots of information. And so that can hinder, because they could say, you were here 2 days ago, but can you tell me what you said again? Because I'm not sure. I've gotten so much information. And I think that just being in an acute care setting, we have to be sensitive to that fact and find ways of reinforcing patient education, not just for the patients, but for their family members and their caregivers, then also the other professionals who are working with the patients as well. So we can all reinforce the same information for the patient.
Has there been anything that you found specifically that you like? Any tips or tricks of the trade?
I like pulling up a chair and sitting down with a patient. As a matter of fact, I just had a student I was working with yesterday, and she was doing she was going to consent the patient in order to do a case study. And I said, you know, when you go in there, make sure you sit down, because you don't want, there's this inherent power asymmetry, because you're the practitioner and the patient is the patient. And so I find that a trick to empower the patient is to sit down and talk with them so that we're on the same level, we're eye to eye, and to really invite them to the table of their own care, and to just level that power asymmetry for them. I think it builds rapport, and it helps the patient to really get involved in their care, maybe in ways that they didn't think that they had to.
Or had options too.
Had options too, yes.
I love that. I was talking with somebody this past week about that physical environment and the physical space that you create. So the environment of empowerment is not just sort of the emotional, but it can be that physical environment too. And I was talking about, so I'm an outpatient and pelvic floor. And so one of our rooms has like a desk where you sit at the desk and then the person's on the other side of the desk. And I've said from the get-go that I'm not going to sit in that room because I don't want a desk in between me and my patient. Like, I just can't handle it. So if I can, I always sit sort of next to, so that we're speaking together. This is a conversation. Sometimes I'll even pull up my computer with images and show them that way. Now, again, it's very different setting than acute care. But I love that you brought that up, that physical and almost psychomotor kind of skill of patient empowerment is something that I don't think we learn a lot about in PT school. But hopefully we all learn as we go on the job, sort of. This is kind of why we're doing this, though, is because we think that we need to be more intentional about those skills. So
I can't say that I learned a job in physical therapy. I can say that I became way more sensitive to it over the years, and it became a mandatory part of my research pursuit, actually, because the area of research that I like, the methodology that I like, is really empowering the participants and inviting them to the table to be co-researchers with you about what we're researching, because they are experts in lots of things that we are not experts in. And so I've kind of adopted that that mentality with my patients as well over the years.
Why don't you just tell us what you're doing, Jerenda? Tell us about, I feel like I'm on the edge of my seat being like, okay, what is it? Like, tell me, what is it that you're studying?
I'm looking at experiences of racial microaggressions that people of color experience in physical therapy. And the reason that I'm looking at it, first and foremost, because I had a glaring experience when I was in physical therapy school. And my professors segregated the class into two student groups. There was the white guys and the janitors, and the students of color were in the janitor group. And it was a joint mobilization class, and it was designed to be a competitive learning environment, but it didn't feel like a game. And the problem, outside of the overt problem, is that the students of color started having declining grades in that class, because there's a lot of psychosocial burden associated with the event. And so I saw this pipeline from disparate care to poor outcomes. And I said, oh my gosh, you know, when these students, when the grades come out and the transcripts come out, they're permanent. And when people see those outcomes or that transcript, they won't know the story behind what happened. All they know is the transcript. And so it got me thinking about those pipelines. And over the years in the profession, I've seen and heard a lot, story after story. And it got me thinking, what's going on with my patients' outcomes here? So when I started to look at the data, I saw that people of color have poor outcomes. They have longer lengths of stay in rehabilitation facilities. They have inability to care for themselves following a stroke. They have more difficulty reintegrating into community settings. They have psychosocial and even financial burden because of inappropriate utilization of services, because they're not necessarily moving through the system appropriately. And so I said, well, I know that these racial microaggressions are happening in the academic environment in the PT programs. I know that it's happening amongst my colleagues because I experienced it and I hear my colleagues. Is it happening with the patients as well? And could it be a contributing factor to poor outcomes? And so that led me to say, hey, let's sit down and talk with people who have had these experiences to find out. As a matter of fact, just last week, one of my colleagues had a situation where she committed a very unintentional microaggression, and it was a white colleague of mine, and she was working with a middle-aged Black man, and so she was interviewing the patient to find out about his home environment to make sure that he's going to be discharged to a safe home environment, standard care. And so she asked him, she said, well, is your daughter home or does she go to work during the day? And the patient said, well, why would you even assume that my daughter doesn't go to work? To ask me if my daughter does go to work. And so he got very, very upset. So much so that they had to have a third party come in just so that she could finish the assessment with the patient. So the big question is, what happened with the exchange of information there? What wasn't shared? What wasn't communicated? And how might that have impacted the patient's outcomes? Was everyone so emotional after the situation that they forgot to say, oh, by the way, or maybe the patient then forgot to ask a very pertinent question or to share something very important about himself that would have helped therapists make good recommendations for his care. And so that's the same question mark that I'm trying to get at. What can we do to help our patient outcomes?
I think it's so interesting to think about this, and it's such a big topic that you're tackling, obviously, and I'm really, really grateful that you are doing this work. That's why we wanted to speak with you. So first of all, thank you for doing it, and thank you for committing to it, and we support you. I think it's interesting to hear about the experiences that the healthcare providers who happen to be people of color or in minority populations or whatever it is, how they have experienced the academic setting becoming a healthcare provider, and how that probably deters people of color from becoming healthcare providers. And then we end up with this environment where there's less diversity for our patients. And so to me, that's like, well, obviously that would lead to more incidences of microaggressions then, because there's more differences, and usually unintentional. But I think it's really interesting to think about kind of how this is happening from both ends. It's happening from the students becoming healthcare providers, or even getting hopefully to the point where they can decide to become healthcare providers. You know, the way that our educational system is, there may not even be those opportunities for people to even see themselves in your role or our role, right? But then also on the patient side and how that actually translates to patient outcomes. And I think we haven't done that work in physical therapy. So I'm just really, really happy that you're doing that. Can you share maybe some advice for us about, and this can be from what you've learned or just from your experience, we'll take any of it, but can you give us some advice of what we should watch out for as physical therapists when it comes to this topic?
If I could just rephrase that a little bit, one of our, oh, I'm so sorry that it's echoing. One of our pillars is clinical reflection. And so like that question of what questions of reflection can we ask ourselves in those moments after the situation or to mitigate it before?
I think that is an outstanding question, because a lot of times we talk about the issues, but putting forth an action plan is not so easy, breaking it down. And I'll tell you, in order to break this type of action plan down, the first thing we have to do is take a deep dive inside. And you don't have to share your deep dive with anybody, because let me tell you, we have all committed microaggressions. No one single person is exempt. We've all done it, whether it was unconscious or maybe it was overt. It doesn't matter, we've done it. So the first thing we have to do with ourselves is to take a deep dive and say, hey, what are my assumptions? I mean, really be honest about what childhood looks like, what teenage years look like, what undergraduate or young adult years look like, what your middle age, what your older years. Really think about the people who are in our lives who have influenced us and some of the things that they've instilled to us. We have to be honest with ourselves about that, because if we're not honest, then the action plan ends right there. The second thing we have to do is we have to, once we learn our assumptions, we have to give ourselves permission to suspend them, let them go, and say, you know what? It is okay for me to no longer think like that, and to bracket that and put it away and acknowledge that it's there and say, I'm done with that. And I'm going to work really hard to leave it over there. Because once we do that, now we can approach the next person with a fresh perspective. I don't think that we give one another enough credit in terms of us being experts in our own lives and our own experiences. We might not be experts across topics, but we're experts in what we lived. And if we can hear someone's perspective about how they've lived and what they've experienced, and we've given ourselves permission to suspend those assumptions, now we're learning new knowledge. That's exactly what new knowledge is. Now we have an openness to hear it the way that someone else is expressing it, as opposed to the way that we thought about it before. And once we do that, we have new knowledge and we're open and we hear, and that's how we learn, and that's how we meet one another. It's a lot of tough work.
I think learning to say, I've changed my mind, or thank you for talking with me about this or sharing your story with me. That gives me a new perspective. Those are hard things for some people to say. And I think it's even harder when you are a healthcare provider to acknowledge either I made a mistake or I said something I shouldn't have, or, you know, even acknowledging like, I didn't have that perspective before I met you.
Mm-hmm.
So I think it's always good for us to remember that we're just human beings.
Mm-hmm. Yeah. And especially in healthcare, I mean, and we're kind of talking about life, and we're kind of talking about healthcare, and we're blending the discussion. Especially in healthcare, we are groomed as providers to take on a powerful relationship as it relates to other people, as it relates to our patients. We're groomed to be powerful. We're groomed to make decisions and to stand on them. We're groomed to command attention when we walk into the room. We're groomed like that. And so this is dismantling the grooming that has got us through our education process, dismantling the grooming that has gotten us through our residencies, through our board examinations, the grooming that has projected us into one position after another position, and that has allowed us to climb the ladder. We're saying, no, don't come down off the ladder, but let's dismantle some of the things that we have been taught. And it's tough work. It is. It's really, really tough work. But that's why you have to give yourself permission to do it, and permission to feel comfortable about doing it. And that's why I think sitting eye to eye with your patients is so important. To say, hey, let's break down these barriers. Let's break down these walls. Let's be right here and just have a conversation.
You can be an authority in your field without being authoritative.
Yes, please say that again.
I think it's good, right? Being an authority in the field without being authoritative.
Absolutely.
I think, yeah.
Yeah. It's powerful. I think it's a learned behavior because we're not trained like that.
We aren't. And then again, when we go back to the lack of diversity in our programs, we don't have to confront that if there's this lack of diversity in our PT programs. I mean, speaking of PT only, which I know has a diversity problem, my goodness. I think that only can reinforce the like, I don't really have to think about this, right? Because I'm not hearing anybody else's lived experiences about it. Which actually is a huge disservice to everybody, right? Because, you know, when I'm thinking about it, I think I shared with you in my PT program, I was in a class of 80, and I think there was maybe 1 or 2 people of color in my program. There were also mainly women, not very many men. I mean, there's lots of different ways that that kind of diversity or lack of diversity goes. But in general, I think we know that there's an underrepresentation of people of color for sure in PT programs. But then when we went on clinicals, you know, where did I do my clinicals? I was in Detroit, right? So it's like the people that I was serving, I was not surrounded by those people while I was in PT programs. And we didn't learn from that perspective of like, what are the unique needs of different populations of people in healthcare? And so it's almost like we're underprepared then to go into our clinical fields, depending on where we work, the population that we serve. You know, I just think that's like so interesting to think of how all of these things are interrelated. And I think I also shared this with you too, Jerenda, that I grew up in a more diverse neighborhood. I grew up in Maywood around here. And so I actually feel like so lucky and blessed to have had that kind of upbringing, because I certainly would not have gotten it in my PT program. So it's just, again, it's like diversity and experiences and a variety of experiences from other people. That's really a gift and something to be learned from. So I just love that you're doing that. And so you're doing qualitative research. I love that. I think it's so great.
I am. This is a starting point because this is where the data or lack thereof guided me. And I think that I will always be a qualitative researcher at heart, because I love the openness and the flexibility of qualitative research. I will absolutely dive into quantitative because I am hoping that this qualitative project will lead me down that road so that we can do more dissemination of data findings. But the qualitative piece will always have my heart. Absolutely. And I think that's what makes this leg of my research agenda so easy, because sitting down and interviewing and hearing the stories and hearing the experiences, it's just rich. It's very, very rich information. And I think that the participants feel like they're sharing their stories with me. I don't know that they really understand how much they're actually teaching me. And so, you know, being a lover of learning, the qualitative research is just that space.
Are you able to share any of the questions that you ask your participants?
Yes. Well, I am doing a semi-structured interview, so I only have a couple of questions. So the questions in the interview actually develop according to the conversation. But the starting question is, first I want for the participants to describe racial microaggressions to make sure that we have the same working definition. Because if we're not talking about the same definition, then you know, that's going to skew the findings. And I don't want that to be the case. I want for the findings to be true to life. And so the next question is, have you experienced racial microaggressions while seeking physical therapy? And can you tell me about that experience? And that's it. Everything else is based on what they have to say, and kind of hearing the paths that they're going down, maybe encouraging to say, can you tell me more about that? What I'm finding is that when I talk to participants initially, the initial contact, everyone's ready to tell their story, which is wonderful. They'll start telling me and I'm like, wait, save this for the interview. But when we interview, then they may not say the same things. So I'm jotting it down even with that first conversation, so I can say, hey, you know, the first time we talked, you mentioned that, you felt like the therapist didn't expect for you to be compliant with your program. Can you tell me more about that? So I'm just trying to hear it from all these different points of contact with the participants.
What do you feel like has motivated your participants to share their stories?
I think honestly that the current landscape that we have nationally and internationally, where there's just so much unrest and there's just so much social justice going on, that people, they want to talk. People want to say, well, I've had an experience. I want to talk about it too. The landscape, while it's hostile, it's also kind of open to hearing, for this dialogue and for the exchanges. So I think the environment is ripe. I think, 20 years ago, participants would have wanted to talk about it, but the environment was very, very different. And I think that they're encouraged. There's a lot of encouragement around, and not just from a healthcare perspective, from a corporate perspective. Corporations are looking to make moves and change policies and to be more inclusive of people with differing backgrounds across the board. And so people are saying, hey, yes, I want to be a part of this movement. I want to help set the tone if I can. And if my story will set the tone, then that's what I want to do. One person told me, do whatever you have to do to get my story out, because I've learned from this and I want someone else to learn from it too.
That's so inspiring.
Yeah, it is.
Yeah.
Yeah.
That's actually immediately what I thought was, I'm sure, like just personally, I've said and done things that were microaggressions. Like you said, I think we've all committed them in our personal and professional lives. We just have to accept that. But do we always know? Probably not, right? And so because our patient who had that committed against them, that's not their responsibility then to educate me about what I need to do next. And sometimes I think we can reflect and we can say that probably wasn't the right way to go or the right thing to say, but sometimes we also don't know. And so hearing more people's stories in a work like yours, everyone that reads that then hopefully will get to hear what it is they should or shouldn't say, or learn from those experiences that have happened to others, and kind of find themselves in your work. I hope that's what happens. Because again, one of the things that I really, really love about you is that you want this to be actionable. You are not just doing this just to get your PhD and just to do it. You want to do something with it. And I think that's really, really huge. That's everything to me. I don't understand why you would do it otherwise, but it happens. So I just think, again, it's like something that keeps coming up in this year. It's been many, many years, but especially this last year of kind of our reckoning with, hey, we cannot ignore this anymore as a country, is to then say, what do we do? Because I agree with you. We all love to talk about this now, which I think is good, and there's place for that. But then I'm always sitting there saying, so what do I do? Thank you for figuring it out. And I love that you have to you're going right to the source of what happened, what are the kinds of things that happen, and then we can decide on what to do.
Absolutely. Where we're talking about it, we're talking about the historical facts, we're bringing people up to date. And I'll tell you, someone made a comment that I could never unhear. She said, I feel like I was cheated because I didn't learn this earlier. Somebody cheated me by not teaching me this. And I thought, how powerful is that? You know, we can all use that statement with something in life. Someone cheated me by not teaching me. Wow, I love that. And so she said, I'm so grateful that I'm learning about all this, at least now. And so, you know, I'm seeing that companies and organizations are putting forth policies, and they're doing workshops and training. And like I said, a lot of it is surrounding historical facts, and it's talking about, hey, this is what we need to do. But then we leave the workshop and we forget, you know, because a lot of us need multimodal avenues of learning. So what we need to do workshops that are hands-on, not case study on paper, but we need to do role playing and mock, just like back in school, we do mock interviews and sim labs. We have some places at Rush, the emergency room is doing this wonderful, wonderful project right now for their diversity training where they're running simulation labs. And they'll have a patient come in with a whole set of diverse challenges. And they run the whole case scenario and then debrief. And they're getting some really good feedback back because people are responding as if it's a real live situation, even though it's a simulation lab. And so those are some of the things that we need to do. We need to work through, we need to talk through role playing, and we need to make it actionable as we're training and not just textbook knowledge and slides on the PowerPoint presentation.
You are speaking our language. That is exactly what we talk about in terms of being a stronger patient educator and improving those skills of communication and teaching and learning and figuring out how someone's health literacy affects their care, what adaptations you need to make, and all of that. Practice, role play, practice, practice.
Yes, practice, practice, build the workshops, but let's stop and think, who's building the workshops? Are the healthcare professionals who are not informed building the workshops based on what's on paper? Or are we inviting people who have had these experiences to say, these are my experiences, this is real, this is how it made me feel, I have some suggestions for your workshop. Let's try to add some of these elements into the workshop. And that's what it means to really partner with the community or to partner with people who've had experiences to help get real, true to life recommendations on how to then reconcile those situations. And that's any situation moving forward.
I just love you. No, I think I am just so, I don't know. I'm so inspired by what you're doing. I love your voice. Just, I told you this before. I think you just have such a great perspective and outlook. And, you've taken a situation that certainly was not so great. And you've said, I'm going to do something about this. And I think that's just so inspiring. So I don't know. We want to support you. Let us know how else we can support you. Yeah, I don't have any other questions, I don't think.
I have one more question for you. So it is, like Karla was saying, it's hard to know what your community needs when there are so many different types and so many communities around the entire world. If you get placed in one Chicago neighborhood versus another versus Nashville versus the East Coast, it's hard. We can't learn and keep up with so many communities. So once we are in a community, when we start a new job, when we are on a clinical for 13 weeks, what's something a provider could do maybe as soon as they get there, before they get there, to learn about the community they will be in?
I think to actually get out in the community and get out into the field. Learning is in the field. It's not in the ivory tower, as we say in the research world. You can't learn in the ivory tower. You got to come down those stairs and get out into the field and get into the community and learn from the people who are in the community in whatever opportunities you have for whatever community you're in. Just commit to getting down into the community.
I think that's a great piece of advice. And just as kind of a tip, when I was on clinicals, I found churches that I could go to, and that's meeting the community, right? And I was able to have some opportunities with volunteer organizations and things like that. So I think there's a lot of ways that you can do that, but also even just like going out and getting dinner and it can be fun stuff and just seeing who's around. I think it doesn't always have to be so hard. And I agree with you. We think we're doing the learning all in the clinical and during that work day. But actually it's not. It is learning about the community around you too.
Yeah. Talk to the people who are helping you at the restaurant. Hey, how are you? What's going on in this community? People are usually people who live in their community and they serve their community. They usually love their communities, and they talk freely about their communities. Hey, I'm part of an organization. We have a meeting going on next week. Would you like to come? I mean, we would be surprised if we just open ourselves up to becoming part of the community. You know, we don't have to be outsiders. We can work ourselves to be insiders.
That's such good,
Absolutely.
such
Yeah.
good advice.
Yeah.
Thank you so much for doing this and for letting us pick your brain and sharing about your work and all of that. We just really appreciate it.
Thank you, ladies, for allowing me to be a part of patient education and allowing me to be a part of this inspirational work that you all are doing to help educate not just patients, therapists alike, and anyone else who's willing to listen.
Well, thank you.
Thank you.